Yeah, if you can share, I'll be happy to.
Yeah, sure. Take it down.
Yeah, please tell me.
82288
Yes.
94
Yes.
770.
It is 94770. No?
Right. 82288 94 770.
Great. Thank you, ma'am. We are live. Nishant can take
Sure.
over.
Okay.
Yeah. Thank
Okay.
you.
Good evening, ma'am, and good evening, all the participants and doctors. So today we are going to have a webinar, and today the webinar is about managing and preventing menopausal complication. Our guest speaker for today is Dr. Kumudini Jha. So before I start with the introduction of ma'am, so let me give a few intro about our digital page, that is Shield Connect. So let me share my screen. So this is our page, shieldconnect.in, where you can find all the blogs which are been taken by the renowned doctors, and you can have the knowledge sharing regarding all the topics related to women health issues. Then we have a webinar section where you can find all the upcoming webinars as well as the past webinars conducted in our Shield page. Then we have awareness page where you can find the immune booster page, in which we reintroduce the new product, new, which will be helpful as immune booster in this pandemic situation. Then we have another page, which is the PCOS awareness page, where you can find all the videos regarding the PCOS related issue by various doctors in different content language like Hindi, Malayalam, English, Telugu, Kannada. Then we have one more page, which is the special pages for various days like Hypertension Day, Mother's Day, Safe Motherhood Day, GDM Day. So if you click on one day, like I clicked on the World Hypertension Day, so you can find the topics regarding the hypertensions. And we have one more page, that is our leaders, where you can find all the key opinion leaders, where all the doctors who are connected with the Shield Connect page, you can find the details of all the doctors. So let us start with the intro of our guest speaker, Dr. Kumudini Jha. So Dr. Kumudini Jha is MBBS, MD, and then PhD. Ma'am is HOD in DMCH. Ma'am is Clinical Secretary of Darbhanga Obstetric and Gynecology Society. Ma'am was also professor, Department of Obstetrics and Gynecology in Darbhanga Medical College and Hospital in Bihar. And ma'am has also published various articles in international journals. So we will also like to thank ma'am, and I will like to share one thank video. Uh, So I welcome ma'am, and participants, you can ask your questions in the comment section. So at the end of the webinar, we can have a Q&A session with the ma'am. So I welcome you, ma'am, and thanks to connect with Shield Connect and supporting us since from 1 year. So let me hand over this session to you.
Thank you so much, Vishant. This is a real pleasure to be with Shield, and you people been sharing knowledge like anything in the last 1 year. Of course, Corona is not a good thing, I would say, but then in that pretext, at least all of us have got together on this digital platform, and every day you've been sharing some topic or the other with everyone and sharing your knowledge. I think we should thank you for that. So now coming to the topic proper of managing menopause and its complications. Let us have an overview first. Can I have the first slide, please? Yeah. So World Health Organization defines natural menopause as the permanent cessation of menstruation confirmed only after 12 consecutive months of amenorrhea. In general, the natural menopause occurs between 45 and 55 years of age. Now the age is going up. And in India, the range of mean age at menopause reported in different studies appears rather young, between 41.9 and 49.42. According to the Indian National Family Health Survey, carried out between 2005 and 6, about 18% of currently married women in the age of the 30 reach menopause. Next slide, please. Concern has been expressed that rates of premature menopause, that is before the age of 40 or 35, it is quite high in India and may be increasing in certain sections of the population. Premature ovarian insufficiency is the name given to it now. And there are quite a few causes, like you have genetic causes, which runs in families, or mutations are there. Then epigenetic changes are there. Then you have the iatrogenic causes like surgical menopause. Then you have, and in the illiterate population, the hysterectomy is done quite early, especially in this part of the country, for flimsy reasons, which should not be done. Then it could be because of chemotherapy, radiation, could be because of hormonal reasons like hyperthyroidism, hyperprolactinemia, and because of autoimmune causes like the people having SLE. So there are quite a few causes in which this happens, and also postpartum hemorrhage, which is quite common in this part. If it is severe, it can lead to Sheehan syndrome. So, for example, in NFHS 24, that showed that 3.1% of women in the age group of 8% and 8% among 35 to 39 years of age group were in menopause. So it's quite a big, sizable group. It further showed that 22.1% of women in the age group of 35 to 39 years in Andhra Pradesh were in menopause, a potentially significant observation as this state has prevalence of female sterilization at a young age. So maybe because of the deprivation of the ovarian supply, it could have to do something with the premature ovarian insufficiency. Now, these data include both natural and hysterectomy. Natural menopause and hysterectomy. The proportion and absolute number of Indian women at the age of 45 years and above this is likely to increase substantially in the next few decades. We are going to see many geriatric patients with many problems of menopause and perimenopause because the life expectancy has gone up. And according to 2011 Census of India, there were about 96 million women aged 45 years and above, and this number is expected to increase to 401 million by 2026. So you can see the volume. As the postmenopausal years are associated with health risks such as hypertension, heart disease, osteoporosis, and decline in the overall quality of life in this group will present profound further challenges. Next slide, please. So you have to individualize your plan for every menopausal patient. Each woman needs an individualized health plan management. It is important to distinguish between the symptomatic and an asymptomatic person. So menopause plus aging, you can see, so there are symptomatic and asymptomatic group. Now in between is the preventive health. So here comes the role of the physician. No.
Dear participants, there is some technical glitch. We will be right back. So please wait for a few minutes.
Hello. Hello.
Yes, ma'am. Yes, ma'am. Yes, ma'am. You are visible and clearly
Hello?
audible. Yes, ma'am.
Have you got it? Hello.
Madam, there are two systems that is opened in your this thing.
Hello, can you hear me?
We are able to hear at least one. Please close, madam. There are two mobiles that
Hello,
are open.
can you hear me?
Nishanti, please tell him. Tell her.
Ma'am, you have to mute the one part.
Huh? Hello.
Yes, ma'am. We can hear you. You have to mute on the one part. I think you have started one more.
Hello. Yeah.
Yes. Yes. Now we can hear you clearly.
I'm connected.
Yes. Yes. Now you can start with our webinar.
From the Bluetooth. From the Bluetooth.
Yes, we can hear you properly.
Now you are able to see the screen, madam. It is individualized plan for menopause. That is the screen.
So I should take off my earphones.
Yeah. Now there are two. No, one you please mute, and now it is very. Now it is audible, madam. You can continue, madam. Yeah, now you can continue, madam.
Hello.
Yes, we are able to hear you, madam.
Now you can hear me?
Yes, madam.
Okay, and can you see me?
We are not able to see you, but this screen is visible. Individualized plan for menopause. That is the slide that is.
The screen is blank. Can you open it?
Sorry, madam.
There's a black screen on it. Can you open it? Hello.
Madam, screen is visible to all, madam.
A screen is visible to all.
Yes,
okay.
madam. We are in the individual plan for menopause slide, madam.
What is this? There's a black shadow in between.
I don't know, but here the audience are able to see the slide.
Anyways, the screen is visible, isn't it? You can hear me?
Yes, we can hear you, madam.
Okay, so I can continue now. All right?
Yes, madam.
Okay. Sorry for this technical problem.
Okay. No problem.
Hello?
Yes, madam.
Chalo. Okay.
If two systems are open, this echo will come back.
Yeah, I'm just closing one. I'm closing one. All right. Now is it clear?
Yes, madam.
Okay.
You are able to see this slide, madam?
Yeah, we were on this slide of symptoms of menopause. Now come to the next slide, please. Yes. So the symptom complex can be divided into vasomotor symptoms, somatic symptoms, genitourinary syndrome of menopause, and neuropsychiatric symptoms. Shortening of cycles that occurs in late reproductive, next slide, please. Shortening of the cycles that occurs in late reproductive years is a clinical marker for the onset of menopause. Later, there is lengthening of the intermenstrual interval, and some may have sudden menopause, amenorrhea. Now, we have vasomotor symptoms. They are most bothersome symptoms of menopause and the most common reason for medical care. People don't come to us for vaginal symptoms or urinary symptoms so early as they come for the vasomotor symptoms. And this happens more in the urban population than in the rural population. So vasomotor symptoms are associated with a sudden sensation of heat in the face, chest, and persist for several minutes or less. During a hot flush, the skin temperature rises due to peripheral vasodilatation, particularly the fingers and the toes. Along with peripheral vasodilation and sweating, heart rate increases by 7 to 15 per minute. It may take 30 minutes or longer for the skin temperature to return to baseline. Next slide, please. So the duration of vasomotor symptoms in the population-based prospective 10 ovarian aging study enrolled older age women with regular menstrual cycles and followed them over 16 years. Now, the mean age of the participants was 42.22 years at baseline and 51.5 years at the final menstrual period. A key finding that was the median duration of hot flushes reported by from moderate to severe was 10.2 years. So women whose symptoms began around the time of onset of the perimenopause, the median duration of symptoms was 11.6 years. Next slide, please. So here you can see in this was a straw study, that is the stages of reproductive aging workshop that was done in the 10 staging system. Here you can see that in the reproductive age, when you take the menarche, they are classified into -5, -4, -3B, and -3A. So in the initial phase in -5, the menstrual cycles are variable to regular, and in the -4 and 3B, they are regular. There are several changes in -3A. Now, in the menopause transition, there are, you see, they're divided into early and late stages. In the early stage, again, there are variable lengths of the cycle varying by 7 days. And in the perimenopausal, just before the menopause, that is late perimenopause, the interval of amenorrhea is around more than 60 days cycle. Then you go over to the postmenopause, where you have +1A, B, and C, and that comes in early menopause. And in the late menopause, again, so you can see that the hormonal changes are different. FSH, that is low in the late reproductive, in the stage, it is variable. And in the transitional phase, again, in the early stage, it is variable. But it rises to around more than 25 in late perimenopausal age. And when menopause is attained, it stabilizes to more than 40. Next cycle, please. Slide, please. So now, what are the somatic symptoms? Joint aches and pain are commonly reported symptoms among women at midlife. Women who are obese or depressed are more likely to experience joint pain. There also appears to be an association with menopausal status, with peri and postmenopausal women experiencing more joint pains than with perimenopausal women. Now, what about the body composition? Although women typically gain weight during midlife, it does not appear to be due to menopausal status or stage. In the early postmenopausal years, women typically gain abdominal fat mass and lose lean mass. That is, the gynecoid fat is converted into an android fat. That is because of the decreasing amount of estrogen. Next slide, please. So here you can see the skin changes. The collagen content of the skin and bones that reduces, and the estrogen deficiency, because you have receptors in the skin and collagen. Decreased cutaneous collagen may lead to increased aging and wrinkling of the skin, frontal balding, and hirsutism. Hirsutism because the fat increases, the testosterone rises, and in that stage, the testosterone will lead to balding and loss of hair. So genitourinary syndrome, GSM. This happens because of the common origin of the genitourinary system. So there are estrogen receptors in the vulva, vagina, in the endometrium, the cervix, everything. So vulvovaginal atrophy or GSM refers to the physical changes of the vulva, vagina, and lower urinary tract that result from estrogen deficiency. Adversely affects the health, sexuality, and quality of life of many menopausal women. The prevalence of urogenital symptoms in the postmenopause in the IMS study was 15%. It presents as vaginal dryness in 32%, pruritus vulvi in 10% to 17%, and dyspareunia and urinary urgency in 10%. Urinary urgency is therefore a symptom, next slide please, which is treated by estrogen, local estrogen therapy. Physical signs of vulvovaginal atrophy are variable and include reduced vulval fat, vaginal rugae, and blood flow leading to the pale appearance of the vulva. And this is now corrected by you have the cosmetic surgery by laser, and that changes the appearance, and it gives the patient satisfaction of a normal vulva vagina. And we all know that because of the change in the reduction in the estrogen, the amount of lactic acid produced is less. So the vaginal flora is altered, the lactobacilli decrease because they produce the glycogen from the cells. A change from moderately acidic range, which is normally 3.5 to 5, to a neutral 6 to 8 pH, there is a shift in the vaginal maturation index. The maturation index is a ratio between the superficial cells and the basal cells or the parabasal cells. So these parabasal cells go up because estrogen is decreased and the superficial cells are reduced. Now, vaginal lubricants and vaginal moisturizers can be offered for vaginal dryness and dyspareunia. Local estrogen therapy is the first line of management, the only contraindication being active estrogen-dependent tunings. Now, lifestyle modifications, bladder drill, and pelvic floor exercises like Kegel's exercise, we all know, are recommended for urinary incontinence, and they do help them, and that is the first line of treatment. The surgery or say the SUI is not the first line of treatment. Now, vaginal atrophy, as we have said, with aging may lead to dyspareunia, causing disharmony among the partners, causing sexual dysfunction, which is corrected by local estrogen therapy. Acquired sexual desire disorder in some women responds to testosterone therapy. Testosterone preparations meant for males should not be prescribed for women. Tibolone, which is a SERM, is a good option since it contains androgenic activity and can be used to treat libido problems. Next slide, please. So, central nervous system. Now, we all know there are estrogen receptors in the brain also. And that is why Alzheimer's disease has been related to menopause and decrease in the amount of estrogen. So to keep your mental status active, many people keep doing puzzles in the papers. And one of the signs, the early signs are that the patient forgets where she's kept her keys, where she's kept her spectacles. And the ELITE study has shown that Alzheimer's disease, if it is to be benefited, or osteoporosis is to be benefited, then the treatment has to start at less than 6 years before menopause and or within the age of 60 years of age. So the core mental functions are memory, communication, language, ability to focus and pay attention, reasoning and judgment activities of daily life, and visual perception. All these, as we all know, decrease with age. Now, impairment of any two functions is suggestive of dementia. Many dementias are progressive. Early diagnosis allows a person to get the maximum benefit from available treatments and provides an opportunity to plan for future. Next slide, please. For best preservation of memory and cognition, women should be advised about the importance of good overall health, good cardiac and vascular health, exercise, maintenance of active mind, avoidance of excessive alcohol consumption, and measures to reduce the risk of diabetes and hypertension. At present, MHT, that is the hormonal treatment, menopausal hormonal treatment, is not indicated for neuroprotection. Now, what about depression? Many people in the menopause go into depression because at that time the children have left for their own careers. There's an emptiness syndrome. The patient has a poor body image, and there is significant increased risk of new onset depression in women during the menopausal transition compared with their premenopausal counterparts. Next slide, please. Now, what are the cognitive changes? Evidence supports the relation of estrogen to cognitive function. Women face problems with memory loss and difficulty in concentration at menopause. A definitive role of MHT for treating cognitive symptoms without vasomotor symptoms is still lacking. So for preventive effects, it has not been used as yet. Next slide, please. So what are the sleep problems? Peri and postmenopausal women sleep less. That is evident in most patients, have more frequent insomnia, and are more likely to use prescription of sleeping aids. Perceived decline in sleep quality may be attributed to general aging effects, for example, nocturnal urination, sleep-related disorders like apnea. And sleep apnea is harmful for the brain because it leads to hypoxia because of the falling back of the tongue. So there may be chronic pain or depression, and because of this, the patient may be sleeping less, and stress, negative mood, ovarian hormone changes, all these account for the loss of sleep. Next slide, please. Hot flashes, that is night sweats, can trigger awakenings in the first half of the night, but the REM sleep in the second half suppresses the thermal regulation and thus the hot flashes. Hot flashes usually occur because of the increase in the prostacyclins at this stage, which leads to vasodilatation under the skin. Decisions on whether and how to treat with behavioral or drug therapy or both depend on the severity of sleep disturbance, context of sleep problem, for example, distressing hot flashes or stress of life, severity of daytime consequences. Insomnia is identified, next slide. Medical or psychiatric causes of insomnia should be, and if present, it should be treated accordingly. Lifestyle modification should be recommended as the first line of treatment. If lifestyle modifications didn't work, then hypnotics, benzodiazepines, or the other medical agonists, these can be used in the short term, but there is no definite or convincing evidence of its efficacy. Now, these should only be prescribed by supervision of psychiatrists. Just now we are doing some telemedicine, but psychiatric drugs are not at all to be given as advice on the telemedicine. Or sleep experts, they can treat them. So mind-body therapies such as yoga have some evidence, but have some benefit, but evidence still needs to be given and further rigorous to prove the effectiveness. Next slide, please. Now, feelings of upset of control, irritability, fatigue, and blue moods, that is called dysphoria, at middle life may be caused by fluctuating hormone levels that perturb the neural systems transiently. Now, women with a history of premenstrual syndrome, significant stress, sexual dysfunction, physical inactivity, or hot flashes are more vulnerable to depressive symptoms. And that disturbs their family life, relations among themselves. Next slide, please. So we should understand that this is a problem with the patient and she is not getting aggressive. Mood disorders, the most predictive factor for depression at midlife and beyond its prior history of clinical depression. Relaxation and stress reduction techniques, antidepressants, and counseling psychotherapy are options to consider in the symptomatic management. Next slide, please. Now, what about urinary symptoms? These can be distressing because the patient then segregates herself from the social life because she has urge incontinence, stress incontinence. So urinary complaints are common in midlife women, but no link to menopause-related estrogen loss has been identified. Over 50% of women more than age of 50 with urinary incontinence also report symptoms of overactive bladder. Mild incontinence in early perimenopause tends to decline in the first 5 years after menopause. Weight loss for overweight women is a very effective treatment. Kegels exercises, that is pelvic floor exercises, can cure more than 50% of cases of stress incontinence when performed regularly. Several medications are approved for an overactive bladder, like we had oxybutynin, then we can have terifenacin, and now we have mirabegaron. But we have to consider the liver function and the renal functions before prescribing mirabegaron, which is quite an effective treatment. Next slide, please. Now, what about osteoporosis? It is defined as compromised bone strength, serious health threat for aging postmenopausal women by increasing the risk of fracture. America spends millions of dollars, and in the UK, the national health system spends billions of pounds on treating the hip fracture patients because the government pays for it. So 13% to 18% of white American women more than age of 50 have osteoporosis of the hip. Low estrogen levels account for about 2/3 of the bone loss during the first 5 to 7 years around menopause. So therefore, we again reiterate that if the treatment has to benefit osteoporosis and Alzheimer's, it should be started less than 6 years before the onset of the menopause and or within 60 years of age. So definitions based BMD are that you call it a normal score when it is -1, osteopenia when it is between -1 and -2.5, and osteoporosis when the T-score is less than or equals to -2.5. Next slide, please. You have some risk factors, and that is by called the FRAX index, that is the fracture associated index. Now the risk factors, so they are advanced age is 50 to 90 years, parental history of fragility fracture, female sex, current tobacco smoking or weight gain, lost long-term use of glucocorticoids. We all know cortisone reduces the bone density, height, rheumatoid arthritis, low femoral neck BMD, prior fragility fracture, alcohol intake more than 3 units daily, and other causes of secondary osteoporosis. Next slide, please. Osteoarthritis. Epidemiological studies of a potential role of estrogens in osteoarthritis showed two very different findings. First, that estrogen deprivation at the menopause seems to be associated with increases in the frequency of knee, hip, and finger osteoarthritis in the severity of hip osteoarthritis. Second, MHT for menopause may decrease the incidence and progression of hip and knee osteoarthritis. Next slide, please. Now, in the cardiovascular disease, initially in the early stages, in young ages, the male supervene the incidence of CHD. But as age increases, the female and the male ratio is 1:1. CVD, including CHD and stroke, is second leading cause of death among US women aged 45 to 64 years. Leading cause of death for women more than age of 65. CHD death rates in younger women ages 35 to 54 are increasing for the first time in 4 decades, secondary to obesity, diabetes, and hypertension. And this is thanks to stress. Next slide, please. So for a better cardiovascular health, next slide, please. Now this is total cholesterol should be 200 milligrams per deciliter, HDL 50, LDL cholesterol less than 100, BP should be between 120 by 80, fasting blood glucose should be less than 100, BMI should be less than 25 kg per meter square. The patient should be doing physical activity more than 150 minutes, excuse me, please, a week, or moderate activity more than 75 minutes per week, vigorous or both, healthy, DASH-like diet. So diet, physical exercise is very essential for bone health. And if you, next slide, please. If you take only care of the diet, take milk and everything, calcium, but you do not exercise, it's not going to be incorporated into the bone. Now, what about cancer? Menopause is not associated with increased cancer risk, but because cancer rates increase with age and cancer is a leading cause of death in women, screening for the following cancers must be done regularly. Breast cancer. Mammograms are recommended every 2 years for patients above 50 to between the age of 50 and 64 and 74. The WI study says, the WHI study, they showed that only estrogen, when given as MHT, does not increase the risk of breast cancer. But in the nurses study, after which people were scared of taking hormones and pills, was that they say that is only estrogen-containing pills do have an increased chance of breast carcinoma. Progesterone promotes the cancer, which is the tumor, which is already present over there, and it increases the density of the bone, the breast. So this leads to, when used for more than 5 years of use, it has been seen like DNPA. When you give for a prolonged period, there are chances of increased chances of promoting the breast tumors. Tibolone, again, when used for a prolonged period, in the Finnish study and the French study, they showed that it increases the chances of breast carcinoma. Colorectal carcinoma, every 10 years, it should be there should be an examination, or fecal occult blood test should be done, sigmoidoscopy or barium enema every 5 years, beginning at the age of 50. Endometrial carcinoma, evaluation of any postmenopausal bleeding with pelvic ultrasound is a must, and a hysteroscopy guided endometrial biopsy should be done. In these patients, bezidoxifene is given, but that increases the chances of endometrial thickness. Lazoxifene is better. It has no effect on it and on the estrogen thickness. Ovarian carcinoma, there's no satisfactory screening test, but timely evaluation needs to be done in patients presenting with symptoms of bloating. Otherwise, they go from one doctor to the other that they have gastritis, and for that they keep changing treatments. Then any patient complaining of pelvic pain or urinary urgency must have a TBS done. Cervical cancer, the Finnish study said that estrogen increases the chances of cervical carcinoma. Pap test should be done every 3 years, or if you do a combo test, that is with HPV, every 5 years. And after a normal report, 3 years in a row for women ages 50 to 64 years. Screening not necessary in a patient's aged more than 65, with 3 or more normal Pap tests in a row, no abnormal Pap tests in the past 10 years, or 2 or more negative HPV tests in the past 10 years. Next slide, please. So now, coming to the treatment. Next slide, please. The hormone replacement therapy. You have tablets, patches, or creams. It is used, like creams are used for, as we've already talked, for the urogenital symptoms. It is very good. Patches, when there are chances of VT, then do not use tablets. If it is really needed, you change over to patches because it benefits by the avoiding the first bypass. Is used to replace estrogen ovaries no longer made during and after menopause. Hormone therapy may have either estrogen alone or estrogen plus progesterone. Now, generally, progesterone with estrogen is necessary in a patient who has a uterus to prevent the unopposed action of estrogen on the endometrium. And generally, use of HRT for a short period of 3 to 5 years has been devised. Reduction of dosage should be done as soon as possible. So the indications are relief of menopausal symptoms, prevention of osteoporosis, and to maintain the quality of life in menopausal patients. Special group of women whom HRT should be prescribed are those patients with premature ovarian insufficiency, as we've already seen, gonadal dysgenesis, and surgical or radiation menopause. So we see here that those without a uterus, only estrogen can be given. Those with a uterus must be given estrogen and progesterone. And vaginal estrogen is very beneficial for patients with genital urinary symptoms. Next slide, please. So what are the risks of hormone therapy? Endometrial carcinoma, we've seen that estrogen promotes it, so progesterone has to be given. Venous thromboembolic disease, increased risk within 1 to 2 years after initiation of hormone therapy. Breast carcinoma, increased breast density with progesterone via proliferation of estrogen-dependent mammary tissue, making it more difficult to detect breast cancer early with the mammogram. And we've already seen that progesterone is a promoter of the tendency of the breast to produce tube. Ovarian cancer, more than 10 years of estrogen therapy has been seen to affect it. Cerebrovascular accidents, rapid metabolism, and increased incidence of gallbladder disease has been observed following due to the rise in the cholesterol when you're giving HRT. Commonly used estrogen are conjugated estrogen, 0.625 to 1.25 milligrams daily. The other types of estrogen we have is ethinyl estradiol, and you have estradiol valerate. And progestins can be given in as medroxyprogesterone acetate. And you can give it as an LNG also, as an IUD, when the patient is not compliant. Considering the risk of hormone therapy, should be used with the lowest possible dose for a shortest period of time. Low dose of oral conjugated estrogen, 0.3 milligram daily, is effective and we give it for a maintenance dose with less side effects. Next slide, please. Progestins. Now, what about that? Patients with a history of breast carcinoma or endometrial carcinoma, progesterone may be used. It may be effective in suppressing hot flushes and in preventing osteoporosis, where estrogen is contraindicated. Medroxyprogesterone can be given acetate in a dose of 2.5 to 5 milligrams per day. And as we've already said, LNG is a levonorgestrel impregnated IUCD is a good option. Next slide, please. Next slide, please. Now, tibolone, yes. Tibolone is a steroid having weakly estrogenic, progesteronic, and androgenic properties. It prevents osteoporosis, atrophic changes in the vagina, and hot flushes. It is a good drug for vasomotor symptoms. It works very well. It increases the libido also because of the testosterone in it. A dose of 2.5 milligrams per day is given, but you cannot give it for prolonged treatment. If you are, you must always keep a watch on the breast and the screening for it. Next slide, please. So now what are the prescription therapies? When laxatin, it is the effectiveness has been proven, but it should not be given when in women taking tamoxifen. It has gastrointestinal side effects, and so has desvenlafaxine, which is similar to venlafaxine. It has also gastrointestinal symptoms and newer medication compared to venlafaxine. Fluoxetine that we give for depression, and it does not have daytime sedation. That also changes some bowel habits, causes nausea, and it has improvement in hot flashes and has been shown to be well-designed studies. Paroxetine, again, that has nausea, dryness of mouth, weight gain, but it tends to be more effective for sleep disturbances and people suffering from insomnia and hot flashes. Escitalopram, that causes improvement in hot flashes, and it is also to be given at night so that because it helps in causing it reduces the depression. Gabapentin causes fatigue, dizziness, nausea, disorientation, and because of the dizziness it causes, many people drop it out, so it should be given at night, but it helps in sleep. And clonidine is usually not given because of the dryness of mouth and drowsiness it causes, and because it reduces the blood pressure by its central effect, but it relieves the hot flashes. Now, what about next slide? Soy, phytoestrogens, black cohosh. Now, according to Cochrane, increased interest in soy flavonoids that was given, but over the time, no conclusive evidence of improvement in menopausal symptoms was seen in 43 randomized trials. A meta-analysis of black cohosh also showed it is not dependent on which you can relieve the symptoms of the menopause. Thus, isoflavones are not a suitable alternative to hormone replacement therapy. In this study that was done, a double-blinded study by Sylvia and Levis, they found that in this population, the daily administration of tablets containing 200 milligrams of isoflavones for 2 years did not prevent bone loss. So it is not a replacement for HRT. Now, what should an ideal menopause solution be? It should regulate endogenous estrogen to non-reproductive or reproductive organs, should offer symptom relief as good as HT, without the risk of cancer, VTE, and stroke, which may be associated with HRTs. So, some SERMs have this benefit. Like you see here, the estrogen affinity to ER, it should upregulate in non-reproductive organs and downregulate in breast and reproductive organs. So you see here, there are other options like medical herbs, concoction of these, like you have cinnamic acid, and but these are just temporary things and a natural remedy used for hundreds of years when there was no HRT, but most people do not use it now. Now, what is estrogen 100? That regulates estrogen affinity to estrogen receptors. Here you can see it is almost like an ideal estrogen HRT, upregulates the estrogen affinity to ER in non-reproductive organs, like vasoendothelium, the CNS, and the bone. It prevents mood swings, hot flashes, and it improves the BMD. But it downregulates the estrogen affinity receptors in the reproductive tract, like the breast, and in the endometrium. It reduces the proliferation of the MCF cells, and therefore it reduces the chances of carcinoma. Osteocalcin, when it was tested after 1 year of estrogen therapy, in this study done by Heiko Lee, and here you can see it decreases significantly. The osteocalcin level, alkaline phosphatase, is significantly reduced after 1 year, and the bone mineral density that has been increased. So you can see that it causes an increase in the bone mineral density, the serum growth hormone, and it reduces the serum osteocalcin, serum triglycerides, and serum alkaline phosphatase. Next slide, please. Next slide. So there was an evaluation of effectiveness and safety of estradiol ERG done on perimenopausal women for 1 full year by Kayoli, and they concluded that in the treatment of estrogen for 12 months, the human growth hormone was significantly increased. The effect and improvement on bone metabolism markers was shown, and the increase of femoral bone density was observed. However, increase in weight and BMI was not shown, and the increase in the serum triglycerides, as is commonly observed with HRT, was not observed with estrogen. So in result, while side effects that is common with HRT were not observed in 12 months treatment, benefits were definitely observed. Here you can see in the Kupperman index, the menopausal index, the KMI index that went down, hot flushes went down,
And here, the other treatment apart from HRT is the therapeutic lifestyle management. There are three things to it. The patient should eat right, they should do a proper exercise, and then take the medications as required. Therapeutic lifestyle management, like physical activity, targeted, and exercise, nutrition, avoid alcohol, tobacco, stress during strategies, meditation and face respiration definitely help, massage, hobbies, and then nutrition, emotional stability, positive attitude in life, family involvement, and spiritual attitude. Sleep should be good. The whole family should understand that this person is in a problem and should not be agitated by her mood swings. So in the nutrition, it has been, the recommendations are, next slide, please, next slide, please. So the recommendations in the diet are sugar, not more than 6 TSF per day, salt, 1.5 TSM or 3 to 5 grams per day, oil, 2 tablespoonful per day, fruits should be at least 100 grams per day, vegetables 300 grams per day, and drink at least 8 glasses of water every day. And if you add flaxseed, cinnamon, fenugreek, soft in salads and curds, that is definitely going to help. Avoid more than 200 milligrams of caffeine per day. Limit intake of 2 to 3 cups. And 1 cup of brewed coffee is equal to 120 milligrams of caffeine. High level of caffeine also causes infertility, as we know. Now, 65 milligrams of caffeine is present in 1 cup of instant coffee and tea. So be careful how much coffee you're swallowing down or tea. Consume a minimum of 500 to 600 ml of milk or curds with low fat to build the calcium bank in bones. Support it with lots of vitamin C rich fruits and vegetables to favor calcium absorption. Now that is also important. What is the calcium that you take? Now about sleep hygiene, all of us know that at least 8 to 10 hours of sleep should be there. So you avoid large meals at night, exercise properly, have less amount of nicotine and caffeine, and take liquids 2 hours before sleep. Maintain in a dim light and avoid all electronic gadgets. What people do is they keep watching the screen because they cannot sleep, and that worsens because it causes sleeplessness. Now, next slide, please. Management of osteoporosis. For that, we need to do the BMD estimation by a DEXA hip or spine test to know whether there's osteopenia, osteoporosis, or severe osteoporosis, because the treatment will depend on it. Next slide, please. Next slide, please. Now, this is management of osteoporosis. Here you can see that in osteopenia, if there are no risk factors, you can follow for 2 years, then post the lifestyle changes. But if there are no menopausal symptoms, you can give hormone therapy, tigolone, bisphosphonates, raloxifene, and strontium renylate. And if there are major risk factors with menopausal symptoms, then you give HT, tigolone, and bisphosphonates. But in cases of severe osteoporosis, teripeptide is required, bisphosphonates, and calcitonin, apart from calcium and hormone therapy. So management of osteoporosis with fragility fractures, for pain relief, surgical management, calcium, vitamin D, and investigations are done to rule out the secondary causes. And you do a follow-up with the BMD spine DEXA test and the bone markers for monitoring therapy. So lifestyle changes, pharmacotherapy, teripeptide, bisphosphonates, calcitonin, pain relief in vertebral fracture, and physiotherapy, rehabilitation, and social and emotional support is a must. Next slide, please. So now what is the amount of calcium that should be taken? It should be recommended doses, daily allowances, 800 milligrams to 1200 in the postmenopause. Upper limit of normal is 2500, but do not give too much of calcium. Vitamin D, 1500 to 2000 is a maintenance dose. Now, you can see in the other salts of calcium, they differ in the amount of calcium that is provided, elemental calcium. Like in carbonate, it is 40, citrate 21, gluconate 9, calcium lactate 30, and calcium phosphate tribasic 38. Natural forms of calcium, like oyster shell, bone, may have lead in it. Next slide, please. Now you can see the difference in calcium carbonate and citrate. Citrate does not require stomach acid for absorption, whereas carbonate does. People over the age of 50, citrate is better absorbed than carbonate. And this carbonate has to be taken with meals, but citrate can be taken anytime. and it costs more, but then it is much better absorbed for the value that you pay. Next slide, please. So calcium supplements, and that you have to add thyroid medications, corticosteroids, tetracyclines, and anticonvulsants, and calcium should be taken separately with these. You should not give calcium with this. So whenever you give thyroid medication, as many people are taking thyroid now, so it is important to tell that in the morning it is taken empty stomach, and for 1 hour you do not give any medication or any food with it. Contraindicated in patients with hypercalcemia, renal insufficiency, and with caution in patients of nephrolithiasis. Excess amounts more than 2,500 milligrams a day affect the kidneys and can reduce absorption and other minerals like iron, zinc, and magnesium. Next slide, please. So, cholecalciferol, that is vitamin D3 tablet, or in the powder form, 60,000 international units once a week for 8 weeks is to be given. When you start it, you must know what is the level of vitamin D. So below 20, it is insufficient. You can give it in injectable forms in very deficient patients. It can be taken in a dose of 6 lakhs international units, which is given to correct the deficiency, not to be repeated before 3 months, and may be given after confirmation of persisting low vitamin D levels. Maintenance therapy should be given after 2 months, that is in a dose of around 1,000 to 2,000 international units. There can be hypervitaminosis D also, which may lead to mental confusion also. Don't carry on giving vitamin D. Cholecalciferol tablets or powder, 60,000 units once a month in summer is a maintenance dose. Vitamin D supplements by oral spray or oral tablets, 2,000 units per day. Injection of cholecalciferol, 3 lakhs twice a year, or 6 lakhs IM once a year. Cholecalciferol, 1,000 daily, will raise blood levels on an average by 10 nanograms per ml. Now, what is the implication in the COVID times? In the COVID times, we all know COVID is a thrombogenic syndrome. And with MHT also, there are high chances of VT in some patients. So if you find that there are such chances, then you withdraw the systemic, next slide please. You withdraw the systemic MHT and add low molecular weight heparin in a prophylactic dose. And if it is generally needed, if the patient really needs MHT, then you give a transdermal patch, because the patch will avoid the first bypass and that will reduce the chances of VT. But in these patients, if it is severe, then you have to hospitalize this patient, because then you have to give therapeutic doses of low molecular weight heparin. And in outpatients, you withdraw MHT or switch to transdermal patch if you're suspecting VT. And if there are persistent respiratory symptoms and outpatient monitoring and isolation is required, you withdraw the MHT and add only prophylactic low molecular weight heparin. If using MHT, switch to transdermal, and if using tibolone, continue to use tibolone and add prophylactic low molecular weight heparin. But because these are both thrombogenic conditions, we have to be very careful when we are giving them. Next slide, please. So the take-home messages are: target population for initiation of HT is usually within 10 years of menopause. Otherwise, even if you give hormone replacement therapy, it is not going to benefit so much. And once you stop the HRT, then the menopausal loss, that is osteoporosis, increases more rapidly than it would in non-users. HT initiated in early postmenopausal period in healthy women is safe. Like all medications, HT needs to be used appropriately when indicated, but it is essential that women in the early menopause who are suffering menopausal symptoms should have the option of using HT. The right woman should be given at the right age, the right hormone therapy drug should be given, and the right dose and right route should be used, be it oral or transdermal or vaginal. Next slide, please. Thank you so much for a patient hearing, and be safe. Thank you so much. And I thank Shield, all the doctors who are attending this webinar. Sorry for that technical disturbance, and hope to meet again. Thank you.
Thank you, ma'am. I appreciate your stimulating speech for today and for providing this detailed information on menopause, and as well as giving the various guidance and management regarding the menopause in COVID situation also. So this was very much updated information we received today in this webinar from you. And even one of the participants have told that it was a comprehensive talk indeed. Many thanks to you, ma'am.
Thank you so much. And I must thank Mr. Venkateshan for inviting me and giving me this opportunity. Thank you so much.
Thank you. So participants, we are ending this session today. And we hope we have more sessions with Dr. Kumudini.
Yeah, sure.
Yeah.
Thank you.
Okay. So
And it was a pleasure meeting you, especially from Gujarat.
thank you, ma'am.
Okay, bye.
We will be in touch. Bye.
Yeah, sure.